I need to tell you about something that happened last Tuesday in my clinic that genuinely disturbed me. A woman named Beatrice, 76 years old, walked in carrying a folder stuffed with papers, medical records, test results, imaging reports. She dropped this folder on my desk. It must have weighed 2 pounds, and she looked at me with these exhausted eyes and said, "Doctor, I came in feeling fine 6 months ago. Now, I'm on 4 new medications, I've had 2 biopsies, and I'm scheduled for a heart procedure next month. What happened to me?" I spent the next hour reviewing her case, and what I found made me angry. Not at her previous doctors, they were following protocols, doing what they were trained to do. I was angry at a system that sometimes forgets a fundamental truth about medicine. Here's that truth. Finding something is not the same as finding something that matters. Beatrice had walked into her doctor's office 6 months ago for a routine checkup. She felt great. She was walking 3 miles every morning with her neighbor. She was babysitting her grandkids twice a week. She was living her life. But because she'd turned 75, her doctor decided to run comprehensive screening. Bone density scan, cardiac calcium score, full body CT, extensive blood work. And they found things. Of course they found things. She'd been alive for 76 years. Her body had accumulated the normal wear and tear of a life fully lived. They found osteopenia bone density slightly lower than a 30-year-old's. They found coronary calcium deposits in her arteries that most people her age have. They found a thyroid nodule. They found a cyst on her kidney. They found degenerative changes in her spine. Every finding led to more tests, more specialists, more worry, more interventions. The thyroid nodule required a biopsy, which caused bleeding and left her voice hoarse for 2 weeks. The cardiac findings led to a stress test, which was borderline abnormal, which led to scheduling a catheterization. The osteopenia led to a bisphosphonate medication that caused severe stomach pain. Beatrice went from feeling fine to feeling like she was falling apart. Not because she was actually falling apart, but because we went looking with increasingly powerful tools and found exactly what you'd expect to find in any 76-year-old body. This scenario plays out thousands of times every day across this country, and it connects directly to what I want to talk about today. What actually happens to our bodies as we age, what the first function we sacrifice really is, and why understanding this can help you make smarter decisions about your health. Because here's what most people don't know, what I wish every person over 65 understood. The first thing your body sacrifices as you age isn't what you think. And knowing what it is might be the most important piece of information you'll ever get about growing older. Stay with me. This is going to challenge some assumptions. When I ask my medical students what function declines first with aging, they guess all the usual suspects: memory, vision, hearing, heart function, joint flexibility. They're all wrong. The first physiological function your body begins to sacrifice, and this starts much earlier than you'd expect, often in your 30s, is skeletal muscle power. Not strength exactly, though that declines too. Power, the ability to generate force quickly. Let me explain why this distinction matters so much. Strength is how much force you can produce. If I ask you to push against a wall as hard as you can, that's strength. Power is how fast you can produce that force. If you trip on a curb and need to catch yourself before you fall, that's power. It's strength multiplied by speed. And here's the crucial thing. Power declines 2 to 3 times faster than strength as we age. A study in the Journal of the American Geriatric Society tracked nearly 3,000 adults over age 70 and found that leg power predicted who would become disabled, who would be hospitalized, and who would die far better than leg strength alone. Think about what happens when you lose your balance. You have maybe half a second to activate your muscles and recover. If your muscles can generate enough force but can't do it quickly enough, you're going down. It doesn't matter how strong you are if you're not fast enough. This is why falls are the leading cause of injury death in adults over 65. more than 36,000 deaths per year in the United States alone, more than 300,000 hip fractures, and roughly 1 in 5 hip fracture patients dies within a year. The killer isn't osteoporosis, the killer is falling. And falling is primarily a problem of power, not bone density. Yet what do we spend enormous resources screening for? Bone density. And what do we barely assess at all? Muscle power. This gets to the heart of what I want to share with you today. We've built a medical system that's remarkably good at finding structural abnormalities, but remarkably poor at assessing actual function. Let me tell you about 2 patients who illustrate this perfectly. The first is Dorothy, 81 years old. Dorothy had terrible bone density according to her DEXA scan. Her T-score was -2.8, putting her firmly in the osteoporosis category. Her doctor was alarmed. Medications were prescribed. Follow-up scans were scheduled. Restrictions were recommended. Be careful. Don't lift heavy things. Maybe get a walker just in case. Dorothy followed this advice. She became cautious. She stopped doing her gardening because bending over might be risky. She stopped walking to the mailbox because what if she fell? She sat more, moved less. Within a year, Dorothy had actually fallen inside her house, walking to the bathroom at night. She'd become so weak and unsteady from inactivity that her muscles couldn't protect her anymore. The second patient is Harold, 79 years old. Harold had never had a DEXA scan. His doctor mentioned it once. Harold said he wasn't interested. What Harold did do was strength training. 3 days a week at his local community center, he lifted weights with a group of other seniors. Nothing extreme: dumbbells, resistance bands, body weight exercises. But he'd been doing it for 12 years. Harold's bone density, if we'd measured it, might have been just as concerning as Dorothy's. But Harold wasn't falling. His muscles were strong enough and fast enough to catch him when he stumbled. His balance was excellent because he practiced movements that challenged it. At 79, Harold was functionally younger than Dorothy at 81, despite Dorothy having years of preventive care and Harold having almost none. This isn't an argument against screening or medical care. It's an argument for understanding what actually keeps older adults safe and independent. Now, let's talk about something that might sound controversial coming from a doctor: the problem with too much testing. Modern medicine has developed extraordinary tools for looking inside the human body: MRIs that can visualize tissues in exquisite detail, CT scans that can detect tiny abnormalities, PET scans that can identify metabolic activity. These tools save lives when used appropriately. But they also find things, lots of things that wouldn't have caused any problem if we'd never looked. There's a medical concept called incidentalomas findings that are discovered incidentally while looking for something else. And as our imaging technology has improved, incidentalomas have become epidemic. Consider this. A study looking at full-body CT scans in healthy adults found abnormalities in over 80% of participants. 80%. In people who felt completely fine. Another study of brain MRIs in healthy older adults found incidental findings in nearly 20% things like small vessel changes, silent strokes, cysts, tumors that were almost certainly benign but now required follow-up. The spine is even worse. A classic study in the New England Journal of Medicine took adults with no back pain whatsoever and scanned their lumbar spines. Among those over 60, 93% had degenerative disc changes. Over a third had disc bulges or herniations. Again, in people with no symptoms. What happens when you find these things? You can't unfind them. They go in the medical record. They create anxiety. They lead to specialist referrals, more tests, sometimes procedures. A study in JAMA Internal Medicine tracked what happened after incidental findings on imaging. Within 3 years, patients with incidentals had more follow-up imaging, more invasive procedures, more procedure-related complications, and no improvement in outcomes compared to those without incidentals. We're essentially creating patients out of healthy people. Let's take a specific example that nearly everyone over 50 has dealt with: colonoscopy. I want to be clear, colonoscopy screening has saved many lives by detecting colorectal cancer early. For people between 50 and 75 with average risk, the evidence supports screening. But what about after 75? What about at 80, 85? This is where it gets nuanced, and where I wish more physicians would have honest conversations with their patients. The benefit of colonoscopy screening comes from detecting cancers early enough to treat them, but colorectal cancer typically takes 10 to 15 years to develop from a polyp into invasive cancer. If someone's life expectancy is less than 10 years, the math starts to shift. Meanwhile, the risks of colonoscopy don't decrease with age, they increase. The risk of bowel perforation is higher in older adults. Bleeding complications are more common. Adverse events from sedation are more likely. A study in Annals of Internal Medicine estimated that for adults over 75, the number needed to screen to prevent one cancer death rises dramatically, while the rate of complications from the procedure itself increases. The American Geriatric Society recommends against routine screening colonoscopy in adults with a life expectancy of less than 10 years. Yet, many of my patients tell me their doctors never discuss this, they just scheduled the test. I had a patient, George, who was 82. He had moderate heart disease and type 2 diabetes. His life expectancy was probably 7 to 8 years. His doctor wanted to schedule a colonoscopy, his first in 6 years. We sat down and talked through the numbers. The chance that colonoscopy would find something that would significantly change his lifespan? Small. The chance of a complication from the procedure, given his other conditions? Not trivial. George decided to skip it. He said, "I'd rather spend my energy on things that make me feel better, not on looking for problems that probably aren't there." That was a reasonable, informed decision. I wish more patients were offered that choice. Cardiac testing in older adults is another area where good intentions often lead to questionable outcomes. Coronary calcium scoring has become popular. It's a CT scan of your heart arteries that measures how much calcium has deposited there, a marker of atherosclerotic plaque. Here's the thing. By age 70, most people have some coronary calcium. It's nearly universal. A study found that over 80% of men over 75 have detectable coronary calcium. So, when you screen an older person and find calcium, what have you learned? That they're a person over 70 who has lived a life. But the finding triggers action. A high calcium score leads to stress tests. Stress tests in older adults have high false positive rates showing abnormalities that aren't really there. False positives lead to cardiac catheterizations. Catheterization is an invasive procedure. A tube is threaded through your artery to your heart. It carries real risks: bleeding, stroke, heart attack, kidney damage from contrast dye. The risk of a serious complication is around 1 to 2%, higher in older adults with kidney problems. And if the catheterization finds blockages, it often leads to stents or bypass surgery. These interventions save lives in people having heart attacks. But in people with stable disease, no symptoms, or well-controlled symptoms, the benefit is much less clear. The ischemia trial, published in the New England Journal of Medicine, randomized patients with stable coronary disease to either invasive treatment or medication management alone. They found no difference in heart attacks or deaths between the groups. Let me say that again. For stable heart disease, invasive treatment didn't reduce heart attacks or deaths compared to just managing with medications. Yet we routinely put older adults through this cascade calcium score to stress test, to catheterization, to stents, often starting from a screening test they never needed. All right. I've spent a lot of time talking about what doesn't work or what causes harm. Let me turn to what actually does work for healthy aging. And I'll start where I started, muscle power. The evidence here is overwhelming. Resistance training in older adults is one of the most effective interventions we have for extending health span, the years of healthy, functional life. A landmark study took nursing home residents frail, elderly, average age 87, and put them on a simple resistance training program. After just 10 weeks, muscle strength increased by an average of 113%. Some participants who had needed walkers could now walk independently. 10 weeks in 87-year-olds. In nursing homes, another study, published in the British Journal of Sports Medicine, followed over 80,000 adults and found that resistance training was associated with a 23% reduction in all-cause mortality, independent of aerobic exercise. Power training, specifically lifting weights with intentional speed during the lifting phase, shows even better results for preserving the explosive muscle function that prevents falls. But here's what frustrates me. When I review my patients' medical records, I see endless notes about medications, test results, and imaging findings. Almost never do I see documentation of exercise habits, muscle strength, or functional capacity. We measure what we value, and we've built a system that values finding diseases over preserving function. Let me give you something concrete. A prescription for aging well that doesn't require expensive tests or procedures. This means resistance training at least twice a week. If you've never done it, start supervised a physical therapist, a qualified trainer. The key movements are squats or chair stands, pushing and pulling movements, and exercises that challenge your balance. For power specifically, focus on the speed of movement. When you stand up from a chair, come up briskly rather than slowly. When you lift a weight, move it quickly during the lifting phase, with control, always with control. This maintains the fast-twitch muscle fibers that decline most rapidly with age. Walking speed is such a powerful predictor of health outcomes that researchers call it a vital sign. Studies show that gait speed predicts hospitalization, disability, and mortality more accurately than many blood tests. Don't just walk, walk briskly. Challenge yourself. Your target should be able to walk about a mile in 15 to 20 minutes. If you can't, work toward it gradually. Older adults need more protein than younger people, not less. The anabolic resistance of aging muscle means you need more raw material to maintain what you have. Current evidence suggests at least 1 to 1.2 grams of protein per kilogram of body weight daily, spread across meals. For a 160-pound person, that's about 75 to 85 grams per day. Most older adults don't get nearly enough, especially at breakfast and lunch. Sleep, stress, social connection. These aren't soft, optional add-ons. They're physiological necessities with profound effects on health. Poor sleep is linked to cognitive decline, immune dysfunction, and increased mortality. Chronic stress accelerates cellular aging. Social isolation carries a mortality risk comparable to smoking. If you're not sleeping well, not managing stress, and feeling isolated, another CT scan isn't going to help you. When a doctor recommends a screening test, ask these questions. What are we looking for? What are the chances of finding it? If we find something, what happens next? What are the risks of the test itself and any follow-up testing? How will this change what we do? And will that change improve my life? If the answers don't make sense, it's okay to decline or defer. You are the patient, not a passive recipient of whatever tests are available. I want to share one more story that has shaped how I practice medicine. His name was Arthur, 91 years old, sharp-minded, independent, still driving to his weekly poker game. He came to me because his previous doctor had retired, and he needed someone to refill his blood pressure medication. I reviewed his records and noticed that he hadn't had many of the screenings typically recommended for adults: no colonoscopy in years, no cardiac workup, no recent imaging of any kind. I mentioned this, curious about his perspective. Arthur looked at me with this calm, steady gaze and said, "Doc, I'm 91. If there's something in me that's going to kill me, it's welcome to try. I've outlived my wife, 2 of my brothers, and most of my friends. I'm not going to spend whatever time I have left in waiting rooms and hospitals worrying about what some test might find. He paused, then added, "I focus on what makes me happy. I see my grandkids. I play poker. I tend my vegetable garden. That's my health plan." Arthur lived another 4 years. He died at 95, peacefully, in his home, after a brief illness. He never had another screening test. He never spent time in an ICU. He lived on his own terms. Was that the right choice? For Arthur, absolutely. Would it be right for everyone? Of course not. But Arthur understood something that medicine often forgets. The goal isn't to die with the cleanest imaging studies. The goal is to live well. Let me return to Beatrice, the woman from the beginning with the folder full of test results. After reviewing her case, we made some changes. We stopped 2 medications that were causing side effects without clear benefits. We canceled the cardiac catheterization. Her symptoms were well controlled with medication, and her functional capacity was excellent. Most importantly, we had a long conversation about what she wanted. "I want to feel like myself again," she said. "I want to stop feeling like a patient." So we stripped away the tests and the constant monitoring. We focused on what she could do: walk, play with her grandkids, garden, live. We shifted the goal from finding problems to maximizing function. 3 months later, Beatrice walked into my office looking like a different person. She'd lost the haunted look. She was walking 4 miles daily now, up from 3. She'd started a gentle strength training program at her community center. "I feel better than I have in years," she said. "I think I was being cared to death before." Cared to death. What a phrase. And how often it happens. Medicine has become so good at looking for problems that we sometimes forget to ask whether looking is helping. We've built systems that incentivize testing and treating rather than listening and guiding. This isn't the fault of individual doctors. Most physicians I know genuinely want what's best for their patients. But we're all operating within systems that push toward more tests, more interventions, more billing codes, even when less might be better. Let me close with perhaps the most important thing I can tell you. Your aging body is not broken. It's not a disease waiting to be diagnosed. It's not a collection of abnormalities in need of correction. Yes, things change as we age. Bone density decreases, arteries stiffen, muscle mass declines, cells accumulate damage. This is biology, not pathology. The changes of aging become problems when they impair function, when they stop you from doing what matters to you. Until then, they're just changes. A 75-year-old spine that shows degenerative changes on MRI, but allows its owner to garden, travel, and pick up grandchildren, is not a diseased spine. It's a 75-year-old spine doing its job. A heart with some coronary calcium, but which powers daily walks and an active life, is not a failing heart. It's a heart that's been beating for 7 decades and is still going. We need to stop treating normal aging as disease, and we need to start measuring what matters, not what's on the scan, but what you can do. Can you rise from a chair without using your arms? Can you walk a quarter mile without stopping? Can you maintain your balance when challenged? Can you climb stairs? These functional measures predict your future far better than any imaging study. So, here's what I want you to take away from this conversation. The first function your body sacrifices is muscle power. Preserve it through resistance training, and you preserve your independence. Not every test is a gift. Some findings would never have hurt you, but finding them can set off cascades of interventions that do. The goal of medical care should be enhancing your life, not just extending it. Sometimes that means aggressive treatment. Sometimes it means watchful waiting. Sometimes it means doing less. You have the right to ask questions. Why this test? What will we do with the results? How will this help me live better? Any doctor worth seeing will welcome these questions. Focus on function. Walk briskly. Build strength. Eat enough protein. Sleep well. Stay connected to people who matter. These fundamentals do more for healthy aging than most of what happens in a hospital. And finally, remember that you are more than a collection of body parts to be scanned and monitored. You are a person with a life to live. Make sure your medical care serves that life rather than consuming it. Thank you for watching this entire video. If you found it valuable, please share it with someone you care about, a parent, a friend, a sibling who might benefit from this perspective on aging. And if you're over 65, I have a challenge for you. Tomorrow morning, try to stand up from a chair 5 times in a row without using your arms, as quickly as you safely can. If it takes you more than 12 seconds, or if you can't do it at all, that tells you something more important than any scan. It tells you where to focus your energy, not on finding problems, but on building capacity. Take care of yourselves. I'll see you in the next video.